Good evening, everyone. Thank you so much for joining our Hyalofast Innovator in Joint presentation webinar. We are trying to have our estimate faculty with us tonight to walk through some case study and followed by a Q&A session. Once again, thank you to all the surgeons who have to join us the evening to learn more about the Hyalofast. Now, let me process with the introduction. Joining us tonight from Anika International is Mr. Mustafa Sai, and moderator Dr. Aldo from Indonesia, member of IOSMA, and faculty Dr. Izan Ibrahim from Malaysia. We'll be sharing insight on Hyalofast. Mustafa, I turn over to you.
Yep. Excellent. Great. Well, my name is Mustafa Sai. I'm the director of Anika's international therapeutics business. I'm responsible for our business in Asia, Middle East, North Africa, and provide overarching support for our businesses. I wanted to quickly just give you a very quick rundown of Anika's business, who we are and what we do. We're a company founded in the United States and have been operating for over 30 years. And we are what we like to call the innovators in joint preservation and restoration. We have roughly about 200 employees and we serve about 90 countries internationally. We are also traded on the NASDAQ. We have a growing presence around the world and operate, as I mentioned, in over 90 countries. And over the next few years, our aim and our vision is really to expand more so into Asia. Our manufacturing site is in the United States, so everything that you use from Anika Therapeutics is from the US. Anika's reputation as a business, really our secret sauce, the magic and kind of what makes us who we are, is the magical molecule hyaluronic acid. And what we are able to do with hyaluronic acid is convert it into different materials. So we have a very large range of viscosupplementation products for OA pain management. And we're also able to take that material and convert it into non-woven and woven fibers to produce products like Hyalofast and Integrity, Hyalofast being for cartilage regeneration and Integrity being for tendon augmentation. I'll give you a very quick summary of our regenerative solutions, and then I'll kindly hand over to the team to take us through the rest of the presentation. So Anika's really kind of star product is Hyalofast, and that's what Dr. Izan Ibrahim will be speaking to us about today. It really serves two main purposes. The first one is a structural purpose. So Hyalofast is a non-woven scaffold for the entrapment of mesenchymal stem cells. And because of the way that we make it, it is a very good way for cells to be able to stick and migrate and then start being able to regenerate. As the Hyalofast is in position, it starts degrading. And as it starts degrading, it releases hyaluronic acid back into the transplantation site, which attracts and activates MSCs. To go alongside this, we also have NanoFX, which is Anika's gold standard bone marrow stimulation. This is for, I guess, countries and markets, and also depending on your hospitals, whether or not you have access to BMAC or not. But if you don't and you need a source of cells, NanoFX is a very good option. Hyalofast structural properties. Here you can see some images of Hyalofast under great magnification. On the top left, you can see it. And then as we kind of move to the right and then the bottom left and the bottom right, you can see it magnified. So what happens here is the cells and the MSCs are actually trapped within the fibers of Hyalofast. And here you can see some MSCs loaded onto Hyalofast. The image at the top is an MSC at day 1 onto the material. And then the image at the bottom shows you what happens after 21 days of MSCs being loaded. So you can see it's kind of covered the whole Hyalofast fiber. And as a surgeon, you have the real option and choice to either soak your Hyalofast with cells from bone marrow stimulation, or alternatively via BMAC and PRP. Anika also has recently launched a hyaluronic acid scaffold for tendon augmentation, which is called Integrity. And this is quite different than the collagen-based implants for tendon augmentation in the sense that it has tensile strength, tear resistance, and suture retention. For those of you who are shoulder surgeons and are doing rotator cuff repairs, we also have some very streamlined and quite comfortable to use instruments, which helps massively. And more importantly, staying on the line of hyaluronic acid, you can see what the close-up magnification looks like of integrity. And this really helps with cell infiltration, tissue remodeling, and ultimately thickening. So at the bottom, you can see some histology showing 3 times thicker tendon growth through the scaffold compared to our closest competitor, which is a collagen-based implant called Regeneten. We also have a bone substitute in our portfolio as well, which is called Tactoset. And this is the world's only hyaluronic acid enhanced injectable bone substitute. This makes it extremely flowable. It hardens at 37 degrees, which is body temperature. And once it does harden, it mimics the trabecular bone to give you good structural strength. And its applications really are for bone marrow lesions or insufficiency fractures, cysts, but we also have the indications to augment hardware. So if you are a surgeon who is doing, hardware augmentation, whether it's fracture plates or rotator cuff anchors, and you have soft bone, you're able to inject this. It will convert to a poorly crystalline structure and support the area during healing. And to go alongside this, we also have some unique cannulas. And then finally, on my side, it's just kind of reminding everybody that we are kind of the global leaders in visco supplementation with products such as Monovisc, Orthovisc, and actually the game-changing product, which is Cingal. This is the world's first and only HA plus corticosteroid combination. And the big difference here is rather than a clinician injecting a steroid followed by a hyaluronic acid injection, the hyaluronic acid or the steroid itself is actually micronized and suspended inside the cross-linked hyaluronic acid, which means it's very different than you just injecting a steroid followed by a hyaluronic acid. So without further ado, my details are here should anybody have any questions about Anika, who we are, or the portfolio. If you have any questions, please feel free to reach out, and I'll hand back over to the team. Thank you.
Okay, thank you, Mustafa. And now I'll hand it over to our moderator, Dr. Aldo, please.
Okay, and my name is Aldo, and I will be the moderator of this evening session. I would like to introduce the following speaker. The speaker is Dr. Izan Ibrahim. He is from Gleneagles Hospital, Kuala Lumpur, Malaysia. He is an orthopedic arthroscopy and sports knee surgeon specializing in cartilage regeneration surgery. Hi, Dr. Izan Ibrahim. Nice to meet you.
Hello, nice to meet you guys.
Okay.
How do I say selamat sore, is it at this time?
It's already night time, so selamat malam.
Selamat malam. Okay.
Okay, Dr. Izan Ibrahim will present a magnificent topic about one-step cartilage regeneration solution. And to all webinar participants, after the presentation, there will be question and answer session later. And if you have any question, please use the raise hand feature, or please type in the chat box. And also, maybe please do not hesitate to ask the questions in Bahasa Indonesia because I will translate them into English for the speaker. Okay, without further ado, Dr. Izan Ibrahim, the platform is yours.
Thank you. I'll just share my screen. Can you see the slide now?
Yes, pretty clear.
All right.
Right.
So I'll start my talk now. And we know that we are all here to listen about scaffold, Hyalofast scaffold, which is a hyaluronic acid scaffold which is used to regenerate cartilage. And the procedure is called a one-step cartilage regeneration, as opposed to a two-step procedures usually done using ACI or MACI. So we start off with what is actually a cartilage defect. A cartilage defect is any kind of break in the articular cartilage, either a crack or a full-blown defect. And usually it can occur as a single defect or focal defects, or also occur in multiple defects over different areas. And most of the time, these defects are caused by trauma. And sometimes you can have a focal defect caused by degenerative changes. And the grading system that has been used to grade these defects used usually are the ICRS grading system, and it's graded from grade 1 to grade 4. And if it's reached the grade 4, where the bone is exposed, this defect can further deteriorate to become bigger, and finally it will become moderate to advanced degenerative disease. So articular cartilage defects are actually a spectrum of disease, from just a softening or fissuring of the cartilage to the full-blown degenerative disease as seen in this picture. And we look further into the ICRS grading system. Grade 0 is normal cartilage. Grade 1 is just some cracks or fissures in the surface. And grade 2, if you have a defect which is less than 50% of the cartilage depth. And in grade 3, you have more than 50%. And grade 4, you have a full thickness defect exposing the subchondral bone. And you notice here in this picture, the grade 3 defect can have a subgrade which involve just a ballooning of the cartilage surface or a swelling. It doesn't have any cracks or defect, but if you probe it, you will find that it's very unstable. And actually this is just a cartilage delamination, which is just a time bomb waiting for it to break down. And in general, these kind of blisters are considered as a grade 3 defect, and I would treat them similar to treating a cartilage grade 3 defect. So why do we need to treat these cartilage defects? These defects need to be treated because they are precursors to osteoarthritis. The small defects can progress, and it can expand in the surface area or depth. And studies have shown that 81% of these defects will progress, 15% are stable, and only 4% will improve over a 2-year period of time. So it is worth to try and treat these patients using conservative treatment to make sure that we did not miss this 4% patient who actually do not need surgery. So if you're talking to your patients about these defects, you can use this similarity between the potholes you see in the road, that the small defects can never close itself, but in fact, with cars going through it every day, it can only just getting bigger and bigger with time, bigger in size and also in depth. And 60 to 70% of knee injuries involve cartilage injuries, and studies have shown that those patients with a history of knee injury, they are 7.4 times more likely to develop knee OA compared to those without knee injury. And the reason why it's difficult for cartilage to heal is because the blood supply to the cartilage is very limited. The nutrition or nutrients that supply the cartilage comes from the cancellous bone beneath the subchondral bone, and these nutrients diffuse through the tight mark area to reach the cartilage layers, and that is from below. And from top, you have your synovial fluid providing nutrients to diffuse into the cartilage. And this is to maintain normal cartilage homeostasis. prosthesis. And if you can imagine, if there is a break in the cartilage surface, it's very difficult for this two supplies of nutrients to provide enough capacity for the cartilage to heal. And this was realized by John Hunter in 1743. At the time, he already mentioned that it is a very troublesome thing when you have a cartilage injury, and this is seldom repaired. And it took humans 200 years later before they start to try and attempt to heal cartilage. When in 1959, Preedy introduced the subchondral drilling, followed by abrasion chondroplasty in 1986. The now gold standard ACI was introduced by Mats Bridberg in 1994. This is a two-stage surgery. The commonly used microfracture now is introduced in 1997, and OATS by Haggerty was introduced in 2001. The topic of interest today, scaffolds with cells, was only introduced in 2010, only about 15 years earlier. And means cartilage implantation, which is currently still under investigation, was probably introduced in 2011. So the ultimate aim of cartilage surgery is to provide coverage for these defects, so that these defects will not become increasing in size over time, and to prevent it from becoming bigger and larger. We have to treat the knee as an organ, not just the cartilage, which is important. If you want to preserve the knee, you have to deal with problems with the ligament, which provide the stability, the meniscus, which protects the cartilage, as well as the alignment of the lower leg, of the whole limb. If there is only a cartilage defect, then Hyalofast alone can be used to treat this knee problem. But if you have a meniscus tear, or a meniscus extrusion, or a root tear, or a varus knee, or a ligament instability caused by an ACL tear, you need to treat all these conditions at the same time of the cartilage surgery, or in a two-stage procedure depending on your capability. So what do we do now? If patients come with a symptomatic cartilage damage, and you have to remember that we only treat cartilage damage which causes symptom. If you happen to find a MRI finding of a cartilage defect in the knee, but that knee does not have any kind of pain or symptoms coming from the cartilage, you just observe the patient and treat them only if they develop symptoms. And these patients with symptomatic cartilage damage should be conservatively managed for about 3 months by using lifestyle changes, such as a weight reduction program, a medication, supplements, or intra-articular injections using hyaluronic acid or PRP. And if the conservative treatment fails after 3 months, then we can start to consider the types of cartilage repair surgeries that is suitable in our country and in our capacity. So the aim of this knee preservation surgery or repair of the cartilage is to delay, or even better, to prevent arthroplasty altogether. There are a lot of choices to choose from, and each of these choices have its plus and minus. For example, in a review paper in 2020, it was mentioned that the gold standard at the moment to treat cartilage damage is ACI or MACI, followed by OATS, and only the last one is microfracture. And attempts to improve the microfracture has been done, and we call this as microfracture plus. And one of example of microfracture plus is AMIC, where you do microfracture and you add a matrix on top of the AMIC to improve the result of the microfracture. You can use Hyalofast as an AMIC procedure by doing microfracture and covering the defect using Hyalofast plus and minus PRP. That is, yeah, according to the paper, the most inferior result that you can get from all these cartilage surgeries. The best, the ACI. However, ACI is a very expensive surgery. It involves two-stage, and it's also has got a few number of complications. So an attempt to improve ACI to turn it into one stage rather than a two-stage surgery was performed when they start to use Hyalofast as a scaffold-based surgery and mix it with BMAC and PRP. The only one of the disadvantages is that there is not many randomized control trial or a longer term studies uh, to compare Hyalofast result with ACI. However, there has been a lot of papers that has been produced to show that Hyalofast with BMAC and PRP show a very good midterm results. So what is my preferred surgical treatment option? If you take all the other, if you compare with all the other options available, I prefer a technique which can be used a full arthroscopy so that the wound in the knee is minimal, and this will allow for a better rehab with less pain if we compare to an open surgery. The preferred surgical treatment is best to be a single step surgery off the shelf, meaning I can do it anytime. Just take it off the shelf to perform this surgery. It should be reproducible and is backed by sufficient clinical data. What is Hyalofast scaffold? It is a non-woven fiber. Its diameter is 10 micron. Its thickness is about 2 millimeters. So if you have a defect which is more than 2 millimeters deep, you can put double or triple layers of this scaffold to fill up the defects. Hyalofast is biocompatible, bioresorbable, and the main degradation product is hyaluronic acid. So it is a totally biological material, which even though it's degraded, you know that it will degrade into something which is very native to the joint. The first paper to describe this procedure was published in 2010 by Professor Buddha and his team. And in this paper, they used a Hyalofast scaffold with BMAC, but they took the BMAC from the posterior iliac crest and mixed it with PRP. And the use of fibrin glue was optional at the time, depends on the surgeon. And this fibrin glue provides additional adhesion to the scaffold. So the conclusion of this paper was that the results closely resemble those of ACI in similar lesions. It produces markers of hyaline cartilage, proteoglycans, and type 2 collagen, as opposed to type 1 collagen that you see most commonly in microfracture repair. And the MRI, as you can see in the image, is produce a very good coverage of the defects. If you look at image A and image C, there is almost a complete coverage and healing of the lesion. There are many publications that supports the positive results of Hyalofast, which I can't possibly cover all. And the latest study at the moment is the fast track study currently ongoing in the US. It's a study to compare Hyalofast with BMAC versus microfracture, and it's a prospective randomized control trials and is expected to be completed next year. One of the good paper that describe the positive result of Hyalofast with BMAC is the one that compare with MACI. In this study, it compare 19 patients using MACI versus 18 patients with Hyalofast and BMAC with a 3 years follow-up. And both groups showed significant improvements, but in the BMAC Hyalofast group, the IKDC subjective scores are better, and the histology looks like a Highland-like features, and they concluded that this procedure using Hyalofast and BMAC, the results equal those of MACI. Next, we can probably have a little bit of break for the moment to entertain any kind of questions. Is there any questions from the floor that anyone want to ask?
All right, thank you, Dr. Izan. Yeah, as you said, that we will take some break first for the presentation. At the chat box, we have one question by Dr. Aldiko Sapardan. When is the best time to do a second look of MRI after the application of Hyalofast? So how long do you wait after surgery?
That is a very good question. My protocol is that I don't do second look scope or MRI unless there are symptoms. It means that if the patient is well and there's no pain or minimal pain symptoms, I usually don't do any MRI because it involves cost, and the reason that we want to do it is probably more academic, unless I want to do some study or to compare, then probably I would do it as a protocol. But in general, I didn't do it unless patient requests or unless there is symptoms that requires further investigation. One more question, if there are any
Um,
question.
Okay, currently there is no question.
Okay,
Would you like
we
to continue
proceed
first?
proceed
All right, please continue.
with the surgical technique. Yeah. So, how do I perform Hyalofast surgery? So, the first thing is the patient will present to me in the clinic, and there will be the patient will complain of pain. The most important thing to ask the patient at the moment is the location of the pain, because some patients have multiple chondral lesions in their knees, and only one or two of these lesions or all of them may produce symptoms. For example, if patient come with a medial knee pain, but during the scope, you find that the patient has a lesion in the trochlea as well, which is doubtful whether it can cause pain. I will not touch the one that is in the trochlea, because if you try to treat a non-symptomatic lesion, it will produce pain after you treat it. So in general, is in the consensus that if the cartilage does not produce any symptoms, you observe it and leave it alone, and you treat only the cartilage which produce the symptom. And this is why it's very important to ask the patients their symptoms, whether it's in the patellofemoral joint or in the tibiofemoral joint, and whether it's the medial or is the lateral or as the anterior or posterior. So once you decided to perform the surgery, the first thing you do, of course, is to insert a scope, and you find that in this picture here on the left, you can notice that there is an obvious difference between the unhealthy cartilage and the normal cartilage. And this is where this patient have pain. She has pain in the medial part of the knee, and this is the only pain that he has. But when she walks on the flat ground, but if she go up and down stairs, she will have pain on the anterior aspect of the knee from the patellofemoral joint. And it turns out that she has both defects in the medial femoral condyle as well as the patellofemoral joint. So in this example, I'm showing you the ones in the medial femoral condyle. The first step is to remove all the unhealthy cartilage. You can see here, this is basically useless cartilage. If you probe this lesion here, you can immediately feel the hard subchondral bone beneath. These are basically useless cartilage that did not protect the subchondral bone at all. Hence, it will give the pain to the patient. So you need to clean every unhealthy, useless cartilage until you find a very nice edge like this with a 90-degree wall, a stable shoulder we call it, with 90-degree perpendicular to the base, and a very good clean base, as you can see in this picture on the right. You should remember that the the base should be cleaned up to the calcified cartilage layer, which is a very important healing requirement. If you want to heal the cartilage, you need to get rid of the calcified cartilage layer, which is a very hard layer just before the subchondral bone. So after cleaning the cartilage and the subchondral bone, my next step is to aspirate the bone marrow from the anterior iliac crest and also obtain PRP and mix the scaffold with the BMAC and the PRP. I will put the BMAC first because this is the most important component of the healing. You put the BMAC first on the scaffold and followed by the PRP after that. Then you can start to deliver the scaffold, and before you deliver the scaffold, you should first dry the joint. And drying up the joint is very important because you do not want the scaffold loaded with the BMAC and the PRP to be diluted by water and reduce the strength of the healing capacity. And one of the easiest way to perform a dry joint is to insert a cannula like this. It can be any cannula, and this cannula that I use actually is a shoulder cannula. Once you insert this cannula into the defect, and this cannula should be as close as possible to the defect. So if it's in the medial femoral condyle, it should be inserted into the medial portal. You can put a sucker in to suck out all the excess fluid in the joint. And you can do a bit more cleaning up of the subchondral bone after it's dry. And once it's dried up, you can deliver the scaffold into the cannula directly on the defect. And I usually hold the scaffold just using a grasper at the tip. So and once you reach the defect, you open up the grasper and push the scaffold using the grasper. Once every inch of the defect has been covered up by the scaffold, you then want to compress the scaffold using any flat surface. Like this, I'm using the back of a curette to compress it for about 2 or 3 minutes so that it become very sticky, and it will be quite difficult to dislodge. So these are the options of instruments that you can use to clean the cartilage and the subchondral bone. You can use the curette or the chondrectum set. I don't know whether Indonesia has got this set, but we have it, and some surgeons like to use this. But my option is actually to use a burr to clean the subchondral bone and a shaver to clean the cartilage, and it works very, very fine and is faster than using a chondrectum set. And the use of shaver is a sharp shaver or burr is very important, and it has been shown that if you use a shaver or a curette or a scalpel to clean the area, It is able to reduce cell death and also promote a successful integration of the scaffold with the border of the defect. And this is a very important part of the surgery, is to clean the calcified cartilage layer. You can see that the layers of the cartilage is made of the superficial, the tight mark, the calcified, and also the subchondral bone. So the calcified layer is the layer, the hard layer, which is just above the subchondral bone. And how do you know that you have removed all this? Is you use a curette to scrape the layer, and if you don't produce any sound which is very hard, then you know that you have remove the calcified cartilage layer. This is very important so that this cartilage can build upon the subchondral bone. So all of the technique that I've described just now is summarized in this video. The first step is to clean all the unhealthy cartilage and reach a very good subchondral bone area. It's very important to clean it thoroughly until you can see a bit of bleeding coming from the subchondral bone. And once you have cleaned all these lesions, you produce a dry joint. And in this patient, she has three lesions, one in the medial femoral condyle, and the other one is more proximally in the medial femoral condyle, and one more in the trochlea. So you can see that once the defect is dry, once the knee is dry, it's very easy to. So this is what I'm doing, is I'm moving the joint very fast to make sure that the scaffold did not dislodge. This is another small lesion up there. And also another one in the trochlea. This is the one that causes pain when she goes up and down stairs. So once you have inserted all the lesions with Hyalofast, you can do another round of range of motion test to make sure that it's not dislodged. So remember that the important part of this surgery also is to make sure that the scaffold is inserted below the shoulder. It shouldn't be at the level of the shoulder or above the shoulder, so that it will not dislodge when you move the joint. So as you can see here that the level of the shoulder and the level of the scaffold, there is a bit of room, about 1 millimeter length. And this is important to prevent dislodgement of the scaffold, as well as to allow for a bit of a hypertrophy when the scaffold heals. These scaffolds tend to become slightly hypertrophied when it's fully healed, and if you put it below the shoulder, this will produce a very good looking cartilage which is almost level with the original cartilage. This is how I obtain my bone marrow aspirate. The landmarks to aspirate the bone marrow is the ACEs, the inner table of the anterior iliac crest, and the outer table. And where you aspirate is about 2 centimeters proximal from the ACEs, right in the center between the outer table and the inner table. This is the video showing the technique. So you can walk the needle to make sure that you are in the center. And once you are center, you can just mallet the needle in, and it's very easy to obtain the bone marrow once you get in the correct position. And I usually just use a stab wound less than 8 millimeters long to do this procedure. It's very, very painless after the surgery for the patient. We move on next to a case examples. The first case is a 46-year-old male, a 130 kilograms triathlete with multiple injuries over the years. He presented to me in 2018, that was 7 years ago, with a right knee pain and recurrent swelling. We had actually injected him with hyaluronic acid, but it doesn't work. So we proceeded with surgery, and during the scope, we find that there is a large lesion in the lateral femoral condyle. It's about 2 times 2.5 centimeters. And we treat this patient with a scaffold with BMAC and PRP. And unfortunately, a year after the surgery, this patient had another injury, and we did a second look scope because of this. And we find that the surgery that was done a year before produced a nice looking cartilage. Is very similar to feeling as the normal cartilage. However, this regenerated cartilage is a bit hypertrophied. As you can see that there is a bit of a bump at the border of the cartilage. However, this does not cause any kind of symptoms at all for this patient. And currently, this patient is in Europe running a full marathon. This is about 7 years after the first surgery. This is actually a second loop scope 2 years after the first surgery in the same patient. He had a fall from a bicycle while doing a triathlon, and unfortunately, he injured his medial femoral condyle, his patella, as well his trochlea, which is actually looked very worn out. And all of these lesions were treated with Hyalofast as well. And at the same time, we managed to have a look at the first defect in the lateral femoral condyle. It survived the two falls that he had over 2 years. And at the moment, like I said, he is currently running a full marathon in Europe. Case number two is a 51-year-old lady with a right medial knee pain for a few years. She was also treated conservatively with a PRP and HA injections, but after some time the injections did not work, and we proceeded to do a scope for her, and we find that she has got quite a very eroded medial femoral condyle with no actual detectable lesion. It's very flat and is almost like it is an arthritic knee actually in this patient. So we tried to, this is another lesion more proximal in the medial femoral condyle. What we did for this patient was that we tried to create a defect out of the eroded area, where we clean the unhealthy tissue that's covering the bone, and we clean the subchondral bone as well to produce a detectable defect like this. And at that time, I used a nanofracture or marrow stimulation for my patients. I don't perform nanofracture anymore nowadays. And we did a few perforations for her, and we applied a BMAC with PRP scaffold to the defect, also in the proximal part. And for this patient had a twisting injury about a year plus after the first surgery, and she actually had a minor cartilage tear beneath the medial meniscus when we did a second look scope, and we find that the lesion that we had treated a year before has produced a very nice looking cartilage. And we treated the chondral tear beneath the medial meniscus with chondroplasty. This is the proximal lesion which has been treated, and show how beautiful the cartilage has regenerated. Case number three is a 45-year-old male with recurrent sports injuries and worsening right knee pain and effusion for the past 1 year. This patient, we did a scope and we saw quite a large lesion in the medial femoral condyle extending up to the trochlea. This is actually a video after we clean up the defect. This is actually the original defect. You can see the unhealthy cartilage covering the subchondral bone. We clean up this area. We produce a dry joint, perform a bit of a marrow stimulation, and cover the cover the defect using BMAC, PRP, and HA scaffold. So you need to cover every single inch of the defect so that the coverage of the new cartilage will be complete. So in the trochlear defect, it is quite deep, so I put in a double layer scaffold so that it will regenerate nicely. So once everything is inside, I spray with a bit more BMAC for her, and then we do a range of motion test to test the stability, and it is quite stable. So this is the range of motion test for this patient. You can see that even though with a quite aggressive movement, the scaffold did not detach. This patient fell from his motorcycle 2 months after the surgery, so we did a second look scope for him, and we find that the cartilage that we covered up with the BMAC and scaffold is turning into cartilage, a new cartilage. You can see it's nicely turning into white tissue and immature looking cartilage at 2 months after the first surgery. Case number 4 is a 46-year-old lady. This patient has got a multiple problem. She has got a root tear of the posterior horn of the medial meniscus, a meniscal extrusion, and also a medial femoral condyle defect. These three pathologies are very commonly found in those which in the end up with a very severe medial knee OA. So if you can catch this patient early on by repairing the root tear, also by centralizing the meniscus back to its place, and also repairing the medial femoral condyle defect, this patient will do very well, and you can help to prevent them from getting a full-blown osteoarthritis. So what we did was we centralized the meniscus using this technique. We put in a 2 soft tissue anchor, and then we pass in the suture out from underneath and perform a sliding knot. And once you tie the knot, you can see that the meniscus will go inwards to be more in place like the normal meniscus. And you test, you find that the meniscus is very stable and you can't feel the edge of the meniscus. So if it's extruded, when you test it with the probe, you can easily fall off the cliff here very easily. So after repairing, after centralizing the meniscus, it's very easy to get underneath to go into that cliff. So we also perform a root repair for her. And once these two important procedures has been done, the root repair as well as the meniscal centralization procedure, then we move on to perform a medial femoral condyle cartilage repair. This is a very unique case because the shape of the defect is like a heart shape. You can see that this is the first time I've seen this kind of shape in my life. It's a heart shape in defect in the medial femoral condyle. The center part here is quite normal. These all are just useless cartilage. When I probe it, I can feel the bone underneath. So I proceed to clean up the area. There's a smaller lesion up here in the medial femoral condyle and another one in the trochlea, which I have cleaned before. So once you clean everything, you dry up the joint, then you can deliver your scaffold with BMAC and PRP into the defect, covering all inches of the surface. And you should remember also one of the important thing to do for scaffold surgery is you should clear up or debride all the tissues in front of the defect. You can see here that I've already debrided this area, which before this is quite thick, a tissue of synovium and also fat tissue. Because if you don't clear this area, when you move the joint, it will pull out the scaffold which you have inserted. So this is a very important thing to do. You have to take time to clean the tissue which is very close to the repair area so that it will not catch the cartilage. So it's very difficult to put a single scaffold into a shape like this. So I cut it up into small portions and apply it one by one so that it can cover up every aspect of the defect. So remember that to make sure that when you feel the defect, it should be, the scaffold should be below the shoulder so that when you move the joint, it will not catch on the soft tissue and dislodge. So it's all covered up, then you perform a range of motion test to see whether it dislodge, and you can see here that it does not dislodge. So it's very important to do this. We move up to the trochlea area using the cannula. It's very easy. You have to use this cannula to deliver the scaffold, otherwise you will struggle because this provide a very safe passage for the scaffold directly onto the defect. This small one, if you find it only the only defect here, you won't do scaffold surgery for this. You just only do one microfracture is enough, because microfracture is indicated for lesions less than 1 centimeter squared. So actually there is a small lesion beneath this cartilage, beneath this meniscus here. So I've got leftover scaffold. I just push it below the meniscus to cover that small area beneath the meniscus. So you do a range of motion test again and finish the surgery. So just a reminder, range of motion test is very important so that you are very confident during the rehab process. You make sure that when you move the joint, the scaffold did not dislodge. And this is a lesion in the lateral femoral condyle in a young man. And you can see that despite aggressive movement of the joint, the scaffold stays where it is. This is from another patient in the medial femoral condyle. There's another one here further up. There's 2 lesions in the medial femoral condyle. And even though I moved the joint, this scaffold did not dislodge from this surface. This is another example in the lateral femoral condyle. See, for this patient, it's quite aggressive movement, and even that, the scaffold did not dislodge. Okay, to sum up the effectiveness of Hyalofast, these are the examples of all the second look surgeries that I've done. And this is the one that we have discussed before. A non-contained defect turn into a contained defect, treat with Hyalofast with BMAC and PRP, and a year later, it's turned out to be a very good looking regenerated cartilage. This is the same patient, more proximal lesion, covered up very well. This is a 55-year-old lady with a large defect in the medial femoral condyle. You see, this is a very good example of usually how the defect looks small in the beginning, but once you clean up the subchondral bone and the edges, which is this edge is actually quite loose and unstable, you will end up with a bigger defect, which is absolutely fine. You should not be scared to remove unhealthy cartilage or subchondral bone and leave only the healthy part. So this patient experienced pain in the lateral femoral condyle about a year later, and she actually developed same lesion in the lateral femoral condyle. And we had a look in the medial femoral condyle. We find that the lesion that was treated a year before has been covered really, really well. And we did the same for the lateral femoral condyle using Hyalofast. This is the example that we've seen before. This last example is one of the best that I had over the years, because this comes from a 61-year-old male. However, unfortunately, I don't have the picture before the surgery, but if you can see the new cartilage that has been formed, you can imagine the size of the lesion before the surgery. This is quite big in a 61-year-old male. It has regenerated very well. This patient ride big bikes. She had a fall about 9 months after surgery and developed a subchondral bone edema, and we did a subchondroplasty for him. So during the subchondroplasty procedure, we managed to do a second look surgery, and we find a very nice looking regenerated cartilage in a 61-year-old male. So the last aspect of this presentation is the rehab. For me, I will perform rehab for both the tibiofemoral and patellofemoral joints in patients with a very stable Hyalofast after surgery. These two protocols are the same for tibiofemoral and patellofemoral joint. I will allow them to ambulate full weight bearing only in full extension immediately after post-op, and they should walk with the knee straight for 1 month. But I will allow passive range of motion only, not active but passive range of motion also for 1 month. And he should undergo a very aggressive quadriceps strengthening exercise. So basically, these are the 3 advice that I will give patients when they were discharged from the ward. Only when the Hyalofast that was applied was stable during the range of motion test. If for certain reason I couldn't test the stability due to bleeding or due to the tourniquet time, because I performed the surgery with other procedures as well, or if there is doubt that the Hyalofast is not stable, I would uh, uh, perform the same protocol, except that I will not allow any flexion of the knee for 2 weeks. For 2 weeks, the knee should be in a straight position all the while. Only start moving the knee after 2 weeks. Thank you very much for your time and attention.
Thank you for the amazing presentation, Dr. Izan Ibrahim. So, yeah, while you present, there are so many participants. They are intrigued with your cases, and we have so many questions. Now we move on to the Q&A session. Okay. Um, a question by Dr. Angga Ditya. He asked regarding the location. Dr. Anggaditya and Dr. Roni asked a similar question regarding the location of the cartilage damage that can be repaired with Hyalofast. Is there any restriction regarding the location? For example, the cartilage damage at the patella site.
I don't have any restriction at all. Usually, I will perform um, Hyalofast for any surface, including the tibial plateau, the patella, the trochlea, lateral femoral condyles, and medial femoral condyles, tibial plateau, and lateral tibial plateau. All I have treated with Hyalofast scaffold before. Even for kissing lesions, for example, if you have a patella lesion with a trochlear lesion underneath, you still can perform a Hyalofast surgery because when you apply the scaffold, you will put it below the shoulder. So if you move the joint, it will not dislodge. As long as you put the scaffold below the shoulder, it should be okay.
Okay. What about lesion at the patella site?
Yeah,
Repair it.
I will I will treat patella lesions, and this is one of the commonest site where I put the Hyalofast.
Do you perform it by arthroscopy or open?
Yes, I perform it using a full arthroscopy. Maybe we can have another session to talk about patellofemoral lesions because it's yeah, 1 hour is probably not enough to show the technique.
Yeah, that would be nice. Okay,
Yeah.
move on to the next question. Regarding the size of the defect, Dr. Ronald asks, what is the largest defect that you can treat with Hyalofast? For example, sometimes we get neglected cases which shows an already near arthritic femoral condyle, and can we still treat it with Hyalofast?
Okay, usually those patients with arthritis, they will have varus knee. So if you can treat with Hyalofast, but you have to correct the alignment using high tibial osteotomy. As long as you do that, we are okay to do. I have done quite a number of these combinations where you do a high tibial osteotomy with a medial femoral condyle, Hyalofast, and usually they will have a trochlear lesion as well. So regarding the size of the lesion, um, there is a restriction by the European community saying that you can't, if you have a lesion more than 10 centimeters square, you should perform an ACI or MACI. And this is the gold standard for large lesions. But MACI or AC is not available in Malaysia. So I perform Hyalofast for these patients as well. And so far, the largest lesion I've treated is 8 centimeters squares, 4 times 2 lesions. Yeah, and they did quite well.
I see. Okay, thank you. So
Yeah,
it's 8 centimeter square.
yeah.
Okay. Let's move on to next questions. Question by Dr. Evan. Yeah, he asked about BMAC and PRP. I guess Dr. Izan already explained that he uses BMAC and PRP. What about SVF or growth factor? Do you have experience on it, using it with Hyalofast?
The growth factor that I get from PRP. I don't use any other growth factors because I follow the steps in the from the original paper. They use BMAC, they use Hyalofast scaffold and they use PRP. So I don't use any special growth factors because PRP growth factors is more than adequate.
All right. So there's further question by Dr. Evan. So we saw that in your cases, in your presentation, that sometimes you do the microfracture or nanofracture, but you say that you don't do the nanofracture anymore nowadays. So what is the reasons?
But the first reason is that initially when I did the nanofracture, I know I don't have to do it last time because I've already used BMAC. The reason why we do marrow stimulation is we want the marrow cells to come out from the marrow cavity. But I've already used BMAC, so there's actually no reason for me to perform a marrow stimulation. At that time, I performed a bit of nanofracture because I thought that when you have some blood at the base, it will provide an extra adhesion to the scaffold so that the scaffold will not dislodge. But when further evidence showed that marrow stimulation can cause problem with healing of the subchondral bone as well as a intralesional osteophytes, I stopped doing it altogether. And you'll find that even without the nanofracture, the PRP and the BMAC alone is enough to provide adhesion of the scaffold in the defect.
Amazing. Okay. Let's move on to next question. So some questions about the post-op protocol. I think it's already clear that Dr. Izan mentioned that
Mhm.
yeah, full weight bearing, full extension, and passive roam for 1 month, right? And
Yes.
so we use a knee brace.
I will use a knee brace only for 2 weeks
Right.
to make the patient be aware of the instructions. But after 2 weeks, I find that it's a bit it's pressing on the quadriceps, and it tends to make the quadriceps being compressed. And I take it off, but the patient will still keep on walking in full extension even without the brace. So I only use the brace for 2 weeks only.
Okay, so patient education to the patient is really important.
Yes, very
Mm,
important.
okay. And further questions, a quite common questions by several participants here. Uh, can we use Hyalofast in other side, for example, like in shoulder, like the heel subluxations, in elbow, ankle, or including maybe in trauma case?
I use quite a number of ankle taladome defects as well, but I've never used Halofast in shoulder, as there are surgeons who did Halofast for hips, I think, but I don't do hip scopes. So my main target is knee and ankles. Yeah, ankle has got some good papers showing um, good results for Halofast in the ankle joint.
I see. Okay, further question by Dr. Yasunario. Do you need to re-inject the PRP when the patient came for follow-up about next week, 1 week or 2 week after surgery?
From my experience, you don't really need to inject PRP because the PRP has already been loaded into the scaffold during the surgery, and that this is the most important part of the PRP use is you load it at the same time when you put the BMAC and the scaffold. So I worry also if you put a PRP later on, it will cause some fibrosis uh, or scarring of the surrounding tissue and synovium, and this can potentially cause adhesions as well as crepitus. later on. So I will try to minimize the use of PRP and BMAC even after the surgery so that it will not cause adhesion or fibrosis. And this can potentially cause a quite annoying crepitus for the patient. So just use the BMAC and PRP on the scaffold and it should be okay. Should be enough.
Great. Okay. There's a question by Mr. Mustafa. So, after all of your experience, everything you know about the cartilage and Hyalofast, so is there anything you would do differently for your first few cases that you found?
Um, is there anything different I would do?
Yeah, sorry, Dr.
Yeah.
Izan. So I guess the question was, knowing everything that you know now about cartilage and Hyalofast and having used it for so many years, if you went back to your first few operations
Ah,
and as somebody starting out, is there anything that you would do slightly differently or you wish that you did at the start to make the operation go a bit quicker, easier, simpler?
yeah. The one thing that I've learned is that usually after the surgery, I will inject the excess PRP and Hyalofast into the and BMAC into the joint, so that I do not want to waste it. It's very expensive. But I find that there is a possibility that this excess BMAC and PRP can cause scarring of the surrounding tissue and fibrosis, which is doesn't cause any pain, but it can cause um, crepitus, this hypertrophy of the synovium and the scarring of the tissue surrounding the repet cartilage is a nuisance. And quite a number of times I have to go in and clean up this fibrosis so that there won't be any more crepitus in the knee. It's one of the lessons that I've learned. Another thing is that you should always make sure that you clean the calcified layer very thoroughly, and you check it using the curette. After you debride the subchondral bone, you use a curette and feel the hardness. If it still feel hard, you go in and you debride even more until you find a softer subchondral bone.
Excellent. Thank you so much.
Yeah.
All right. Thank you. So, yeah. So we
I
have
think there is
another.
one question regarding nanofracture. Is that right?
Yes, yep, that's correct. So Dr. Gestan, I just asked about so in case we don't use BMAC and PRP, do we still to do the nanofracture when you apply the Alfast?
If you want a good result, as been shown by the paper by Professor Buddha, you have to use these three components. This is a basic cartilage, basic tissue engineering principle. You have to have a scaffold, you have to have a cell source, and you have to have growth factors. And this triad of tissue engineering is provided by that paper. If you don't have access to BMAC or PRP, the next best thing you can do is to use nanofracture to provide the bone marrow cells and also Hyalofast to top. If you have PRP to put it on top, it's better. But if you don't, it will give better results than just using nanofracture alone. And in using this technique, you can call it a microfracture plus technique. It's just uh, a scaffold that is put to improve the result of the microfracture.
Dr. Izan, I had one further question as well. Obviously, you do a lot of sports medicine knee surgery with ACL and meniscus. Um, during the operation, if you are doing an ACL and say a meniscal repair, where do you implant the Hyalofast? So are you doing your femoral tunnels and your
Oh, yeah.
cartilage preparation first? You then pull the graft through and then you're putting the Hyalofast right at the end? Or I guess
Yes.
what's the order of the operation? Because I think it's quite important.
Yes, you do the ACL, you do the meniscus first, you do the ACL second, and you will do you put in everything except for the tibial fixation. The tibial fixation is second, is last after Hyalofast. So
Excellent. Thank you.
Hyalofast is second last.
Perfect.
Yeah.
Right. So currently, there is no more question in the chat box, but I do have a question regarding that nowadays it's very popular for people to start using the like secretome or exosome, like derivatives of stem cells. Do you have any experience regarding those additional
Um,
biologic?
yeah. Secretomes or exosomes are still very experimental and they are very unpredictable. We don't know how to measure the growth factors or the factors that's inside those preparations. But what I can say is that we obtain secretomes from bone marrow aspirate as well. So if you already have BMAC in your hands, you don't really need all the other factors because you have already fulfilled the criteria for tissue engineering, which is the scaffold, the marrows, the cell source, any cell source, whether it's from BMAC or from its chondrocytes, and also growth factors. If you already have these three triads available, you don't need anything else. And I don't, at the moment, believe in exosomes yet. There's not much paper which provide evidence for this.
Okay, thank you. Sorry, I think we missed a question by Dr. Ronnie. So he asked, in case of patellar dislocation, so usually after a patellar dislocation, we can find there's a big cartilage fragment, the osteochondral avulsion that is maybe still can be fixed at this site at the lesion. So
Oh,
for this kind of
definitely.
case, do you prefer to fix it, to
Yes,
reattach it, or use
yes,
high
I will. If you can attach it, it's difficult to. You mean attach the osteochondral fragment back to its place?
Yeah, I think so.
Um, it's very difficult to get a stable fixation for this. And usually, surgeons will use screws to fix it, but there has been a lot of complications using this. So what I do is that because Hyalofast has given a good results so far, I'll just clean up the area, do an MPFL reconstruction, and put the Hyalofast in its place. That's what I did for my patients. You
All
can
right.
use sutures as well. Yes, yes.
Mhm.
But the problem with this is that you need to be quite very careful with the rehab process because you worry about the sutures. So I and in a knee surgery, the range of motion, early range of motion is super important, and I can do a early range of motion if I use Hyalofast. So usually what I did is I just cover it up with Hyalofast and use the same rehab protocol to move the knee as early as possible. I will move the knee the next day after surgery using a CPM machine. And there is no limitation of movement. You can, if the patient can tolerate 0 to 120 the next day, I will do that.
Nice. Okay. So we have another question by Dr. Yosunario. So how long you have followed your the result of your surgery, and did you examine the new cartilage is as good as the one either biochemically or biomechanically? Well, what about it? I saw in your presentation that you do a second look by arthroscopy. So how long do you think the regeneration process would take off?
Um, I will never do a second look without any reason.
Mhm.
Usually the patient had pain or trauma again to the joint, and I will do a second look to assess the joint. Or if I do a subchondroplasty procedure for the bone, I will perform a second look during the subchondroplasty procedure. And I've been doing Hyalofast since 2010. And my first patient was a gentleman, a 50-year-old man who fell from his pickup truck and had a very large uh, trochlear defect, a grade 4 trochlear defect. In 2010, at that time, the defect is too large that I can't do it using a scope. So my first Hyalofast patient was an open surgery. And this patient came to me about 2 months ago with his wife. And he came because his wife has got knee pain. And his pain since the surgery until now, which is 15 years, he is completely well after the surgery. There is no pain. He can pray normally. He can do all the normal function that the knee can do. But because I'm not a very academic person, I'm a clinician. I don't do studies, so I want to, but I don't have the time. Um, so I will deal with my patients if they have pain. If they have pain, I'll do an MRI, I'll do a second look scope. And of course, there are some patients who fail, definitely. Some, for example, they will have partial regeneration. Only part of the cartilage is repaired. And some, they fell down and part of the repaired cartilage peel off, for example, and become torn. So for this patient, actually, I will actually do the same thing for them. I'll do a Hyalofast again for those patients. And it turned out that they did very well after the second surgery. Even those with a partially regenerated cartilage. So I will not touch the regenerated one. The not regenerated area, I will clean up and I will put a second Hyalofast into there. And they turn out very fine. They turn out very well.
Dr. Izan, I had one last question actually, and I know that we've kind of overrun, but I think it's been a really good conversation and an excellent presentation. Um, how many Hyalofast cases do you think you've done since the beginning, or I guess since the
Since
beginning, and maybe how many a month or week? Just I guess out of personal interest.
probably around 400 to 500 maybe
Oh
since
wow,
2010.
that's a lot of happy knees.
So far, I would say that I can say that it's about 80% of the patients will do very well. Those 20% will probably either they did not follow the protocol properly, or they didn't do good physiotherapy, or they just have a very poor healing capacity. Of course, there's not no 100%, no procedure that is 100%, you know, success rate in this world. So I think 80% is as good as you can get.
And I think that's really kind of powerful because when we think about the literature and we kind of look back at some of like ACI and MACI, is yes, the results are good and stable, but in markets where ACI or MACI is not available due to expense or physical availability, I think for you to be able to do a single stage operation and have, a very high success rate, I think it's you know, testament, I guess, to yourself surgically, but also, I guess, makes me quite happy that Hyalofast is the product that's able to provide
Yeah.
that for you and your patients.
Yes.
Thank you.
And the actual fact is that Hyalofast actually was born out of the need to improve on AC in the first
Yeah,
place. Yeah.
absolutely.
Yeah. Okay, so thank you all participants for the enormous enthusiasm, and I think we are getting near to the end of this session due to time limitation. We have to end the Q&A session. And Dr. Izan Ibrahim, thank you for your insightful presentation and discussion. Yeah, we hope someday we can meet in person and discuss these things together again.
Yeah.
Okay. Now, let me close the session and allow me to hand over the session back to Bido. Cheers.
Thank you, Aldo.
Thank you so much, Dr. Izan. We truly appreciate your time in sharing an insightful overview to Hyalofast. Thank you again, Dr. Aldo, for moderating the session. And of course, thank you to Anika and Mustafa Sai for support the webinar. I am Bido from the Karya Seni Mandiri in Indonesia. Once again, thank you all for joining. Have a great evening.